It's Rio Balloon Day and 7:30 guide direct. 3-5. थोड़ा word up.
We are on the C2. Waiting up.
Okay, diploma.
Dr. Irmat.
7:30 हे दे 7:30 स्टैंड आहे का? लूज करो. Save.
Hello, Hiramat. Are you audible to us?
They are asking, are you audible? Hello?
Dr. Irmat, do you hear us?
Hello. Hi, here in Ruby Hall. Can you hear us?
Yes. Are you audible to us? Hiramat, Dr. Panj
Yes,
here,
we can hear you
Dr.
too.
Michael Henry, Dr. Collis.
Who is that?
Dr. Panja.
Okay, can we show
Hello.
us the first case? Get ready with shake. So we have a couple of discussion cases here. We actually have 3 cases, and we are showing you the first case. The issue here is the patient has a symptomatic same side critical stenosis, but patient has elevated creatinine, so we wanted to keep the contrast down. So diabetes 12 years, hypertension 12 years, and he has had a previous bypass surgery. Can you also see the images, CT angio images? So this is a guide catheter, 8 French, and after, Michel, are you there?
Yes, good morning, Dr. Irmat.
Hi, Michel. So actually, after Michel's last visit, we have switched to guide catheter consistently. We no more use long sheets for carotid because it's so much easier going through the guide catheter.
Yes, I think that's a good option.
This is the symptomatic side, and I will show you the spin images in the next case. So we are working on a FD20, which is a very carotid friendly and peripheral friendly system, and allows us to inject just one contrast, go on spin, so that you can pick up an angle in which you can work completely. So according to the spin, 90 degrees LAO was the best view which most of us use for carotid stenting. And this is a straightforward lesion. Let's see the steps quickly. And we are also working on the fluorosave. That means you have the contrast staying there all the time. And we pass your AngioGuard protection device through that. Patient has moved his neck. So we are here making a balloon. So this is a 3-5 balloon. Next. And balloon is inflated, as you can see. So we injected one contrast in the beginning, second contrast just now. Next. And we bring in a stent which is deployed with the same fluorosave. Next. And you can see we are post-dilating, and this is the time when we injected one more contrast. Next. And show us this is the retrieval of the AngioGuard, and this is the final picture. So total contrast injected in this case was something like 16 ml, and then this was the final picture for carotid. So FD20 Philips system, very friendly on carotids. Can we go to the next case, or you want to raise some discussion issue at this stage? Get ready with the next.
No, it's a good result. And which protection device? AngioGuard?
This is the AngioGuard 7th range.
And which stent? Which stent did you implant?
Precise.
This was Cordis
Cordis, okay.
precise. Can you show us the spin now here? Can you show spin from there?
During the post dilatation, which is size of the balloon you have used in this case? 6? Hiramat?
Hello.
So the audio is very unclear, so
Yeah,
we're
it's
not
clear.
able to get your question. So maybe we talk more and you listen to us today, and we will have discussion towards the end. But this is the spin I'm showing you. So in one injection, you can see the entire carotid in all 180 degrees angle. And based on this, you can choose one single angle which is showing you the lesion best. So this is how we saved contrast in this particular case,
This was a left carotid.
and we treated the symptomatic side. So now we go on to our second case. This gentleman actually has symptoms coming from the right carotid. The Doppler, which was done 6 months back, showed that the right symptomatic carotid was showing 60% stenosis, and left asymptomatic carotid was showing 80% stenosis. So I'm showing you a left image, left carotid, which is critical stenosis. So this has to be done. So we go to the next run.
No,
Now
the run has not come there. The run has not come on there. Show the image. Pathak, show the image. Pathak, show the image, please. Yeah, that's correct.
So this is the asymptomatic side, which is again pretty significant, 80-85% stenosis. Let's see the right side now. And this is the symptomatic side. We did a spin, and this is the picture we thought was correct. So this is not 60% as seen by Doppler. This is clearly a critical stenosis. Can we see the next run? So we have now decided to stent the symptomatic side first. Next run. So we had to take a few angles before we cone down on this angle, which is unusual angle. We are in 50 LAO view, and freeze that. You can see the stenosis is very, very critical, very eccentric plaque, extending from common carotid to the base of the internal carotid on the right side. So the standard steps are, we are with a headhunter catheter, then we put a Terumo wire in the external carotid, and then on that support, we will bring in this JR catheter. So this JR catheter is at the base of the lesion, and we have chosen, see the tightness of the lesion, it's almost 95-99% stenosis. We have chosen AngioGuard as the protection device today, and let's see the next. Many people worry about the diameter of the AngioGuard as a protection device, but see how smoothly it goes through. So this is a JR which is looking towards the right, and AngioGuard 6 trench going through very easily.
6 millimeter.
6 millimeters. So we are now, can we magnify to the fullest?
Magnify. Magnify. Basic magnification.
So stent is ready, stent is prepared.
Yeah.
So we have chosen a 730 stent. I need a roadmap. So the question here is going to be, after we treat the symptomatic side, are we also going to do the asymptomatic left side immediately? The patient needs cabbage as early as possible, And we have some literature evidence, contrast, to indicate that treat the symptomatic one first, go up, get the stent ready, open the stents. Kungewazwa, Yadav. Can you see the music to the ear? This is a doll which we give to the patient. So he's holding it in the left side today.
You can do both sides at the same sitting, but it's always the same problem. The risk is higher, and the risk of hyperperfusion syndrome, because the right side is you had a very tight stenosis. So in case of very tight stenosis, and the patient is hypertensive or not, because the problem, the complication rate is higher when the patient is very had hypertension. Patient is well controlled for hypertension or not? Dr. Irmat, do you hear me? Yes, but is well controlled or not? If the patient is well controlled, you can do both sides. If the patient is not well controlled, we have a risk of brain hemorrhage and hyperperfusion syndrome. So it's better to if the patient is not in emergency concerning coronary disease, it's better to wait 1-2 days. If you have to refer the patient very quickly, because it's not an emergency, but almost an emergency for coronary disease, you can do. But it's better to wait. It depends on the hypertensive status.
Yeah, patient was stable conditions most likely. That is why you can proceed in this.
So
do you hear me?
Again coming
Dr. Irmat?
with a precise body stent. This is a 7x30. We'll place the stent equal distance on either side. We all know that the stent has a slight tendency to jump. So I'm withdrawing the catheter a bit, and my colleague Dr. Makre will be deploying the stent. So till this stage, you can sort of retrieve the stent, but I think beyond this point, that is not possible. So the stent is deployed, and we will come in with a balloon. Generally, stent sizes in carotids are 8 and around. In this case, we did a QCA which showed 6-point odd. So we are with a 7 angiocard. And we'll use a 5 mm balloon to post dilate. 5 balloon. The post dilatation generally we do with about 5.5, and we never go beyond 6 for post dilatation. Though the stent deployed could be even 8 mm in diameter. So it's generally a slightly undersized balloon. Patient has received his morning antihypertensive medications. My colleague anesthetist, Dr. Newargi, is working on his pressure continuously. So we have dopamine as well as nitroglycerin drip ready. Currently, we started NTG. His systolic pressure to begin with was 180, and last many minutes we have maintained the pressure at 140. I think this is very important, as well as post-procedure. The systolic pressures have to be kept like this, and especially if you're planning to do both carotids, I think this is very, very important. So here we are coming in with a balloon, little resistance as the balloon goes in. This is okay, safe. Yeah, we are going up on balloon. Get the retrieval ready, please. So it's generally a very quick inflation and quick deflation. Bauli Wazwa, Yadav, Bauli Wazwa. little bradycardia, rate dropping to about 64, blood pressure remaining fairly steady. And we will withdraw the balloon. Yadav Kaswarte.
Hello.
Go on, talk.
Hello, can you hear us?
We're hearing. Are you audible to us?
Yeah, very much.
Okay, okay.
So this step of post-dilatation after stent deployment, we use it almost always unless we feel the area is heavily thrombotic. So what is the opinion of everybody? Should we go in for a second stent at the same time? Before that, I want to discuss the next case because next case is also pretty similar. Can we get ready with Jane? And
Ramat, Dr. Panya here.
Yes.
If this patient is about acute angulations, about more than 95% lesion, so what are the situation you pre-dilate prior to putting the stent?
Actually, we always pre-dilate. I think we never put a stent directly unless it's a very heavily thrombotic area. The reason is sometimes when you are trying to withdraw the stent, the distal part of the stent can get stuck in the waist of the sort of opened up stent. So I think we have to take care of that. So we generally like to pre-dilate before you deploy. Can you see Jane?
Hey, Jane.
Yes, but if you cross very easily with a protection device, that's the case with this patient. In general, personally, I don't predilate if you cross very easily, because if you cross easily, you pass you cross very easily with the stent, and we don't have any problem. So I think we can do 90% of carotid angioplasty without predilatation. I know it's not the case in US. Tyrone.
Yeah, that's true. The majority of the cases we would pre-dilate.
But in Europe, we don't predilate, and we do a direct stenting in at least 80-90% of the cases. But
all right, we go to the second case. We are just trying to borrow wisdom from the house because we are quite puzzled. See, this gentleman is again a surgical candidate, diabetes, hypertension, smoker. He had right hemiparesis, which has recovered. Can we see the cine? And left hemiparesis, which is recovered. And this is actually the symptomatic side. The symptoms, the recent symptoms are about 2 weeks old. And this is what we are seeing. Can we run that? So when we do an angio, you see a total occlusion and a very faint trickle that is passing forward. So this is the symptomatic side. And I'll show you now the opposite side, the asymptomatic side. And this is the left side. And there is a critical stenosis here. So what is the opinion of the house? In this case, can you show the previous run again, the right again? So this gentleman had seen us about 6 days back. We have given him low molecular weight heparin for about last 6 days. Hopefully, there may be a better flow. And in which case, should we do both together? Or should we do the asymptomatic one and just accept the disease in the right? So what do you feel?
how is the CT scan or MRI?
CT scan is showing an old smallish infarct in the symptomatic side, but nothing very much.
Circle of face is good.
I think in that case, I would prefer to do maybe left side and wait for 2 or 3 days for the second side.
So we do only one side, that is the asymptomatic side.
Yes.
And what if the flows have improved in the symptomatic side? Do we address it or we still leave it?
I think without knowing the status of the intracranial vessels, it could be that the symptoms on the other side are because of hypoperfusion related to the collateral flow being compromised, with the tight stenosis in the vessel that's open. So the one that's subtotaled or string sign or even occluded may be in jeopardy, but because of the contralateral stenosis.
This is coming from the subtotal occlusion side, and the intracranial circulation is heavily dependent on the left, which is giving spillover collaterals to the right side. So the only issue is if the total occlusion has improved today, do we address that since it's a symptomatic side and then do this a little later?
Yes.
All right, just show. So we are back to the case which we are doing.
Switch over to the other. Switch over to the other quickly. Off, Laura. Switch over. Let him switch over to the
We
other.
are already with it.
We are on giant right now.
No, this is a this is live, right?
Yeah. But,
Yeah.
But data is going on giant. Yadav select करे सर ना? We are on Yadav now.
Okay, go off everything. Okay. So we are back to the case which we are doing. Just show me the angiogram. So we are.
Hello.
Yes.
Yeah. Can you hear us and can you see us?
So we are sending a retrieval for the angioguard. Typically, we go very slow at this stage. Close the angioguard, but not snugly, because sometimes you could squeeze out small particles, and this is how it is held, and we just bring it back in one quick motion so that the whole thing has come out. At this stage, it's quite important to back bleed because there could be some air, there could be some debris, which you want to take it out. You ready for contrast?
Yeah.
Small contrast. So pressure is very steady at 140, 145, and that's an interesting situation. So no bradycardia during procedure, no hypotension during the procedure, and we have been able to address this side. Can you go back to run number 1 and show the opposite side?
Run number 1.
So Dr. Collins, Dr. Michel, the opposite side is also showing significant stenosis. This is a spin, and next run, and this is a lesion. And patient is hemodynamically absolutely stable. Yadav Pungewazwa. So I'm inclined to do this because there is a relative need for an early cabbage. Are you all with us on doing the opposite side at the same time? I mean, the issues would be hyperperfusion injury since we are opening both carotids at the same time. The bradycardia could be an issue and hypotension can be another issue. During this right stenting, we have had no issues at all. Of course, we have to wait and see about hypoperfusion, but the other two components are not there at all. So I'm quite inclined to do this simple lesion pretty quickly so that the patient can be scheduled for cabbage.
Yes, if the patient is well stabilized, stable, you can do both sides at the same sitting, yes. And the reason is the cabbage. Tyrone, what do you think?
Can I make a complaint? Hello, can you hear me?
Yeah,
Yes.
very much.
This is Dr. Saroj Das. May I recommend that, suggest that you stage the procedure, the other side of the carotid stenosis be dealt with at a separate stage? The reason being, there is always a risk that there will be a contrast overload. This patient is waiting for a coronary bypass graft, and with a contrast overload, he might develop into acute coronary syndrome.
Actually, I don't think that's a worry today because I think the contrast use is just a very
70.
small contrast, 65 or how much?
50, less than 50 so far.
Oh, we have used something like 30, 35 cc of contrast. And,
Has he
I
got-
don't think contrast.
Has this
creatine-
patient got a good left ventricular function?
Oh
Maybe
yeah,
it's
good
patient-
ventricular function, stable case coronary wise.
And renal function is good.
Yes, absolutely.
Okay.
No, it will okay. I think the patient, in spite of the diabetes as well as hypertension, so you can go proceed because creatine level is normal. But keep in mind, hydration to be continue. So at least 48 hours more after the procedure even.
Actually, as we started, we never did two carotids at the same time, but there has been sizable data, including, I think, Michelle, you also have some contribution to bilateral carotid stenting. We have some reports by Dr. Bhatt, Dr. Marco Raffi, where bilateral carotid stenting can be done not as a routine, but maybe as an exception. So let's go on trace.
Dr. Irma, you still have 2 minutes.
Yeah, I don't think we'll be able to finish the case, but thank you indeed for being us and giving us a lot of help in planning the 3 cases. The first one was a straightforward case, but we had some issues with renal function. We did the total case just around 25 cc's of contrast. The second one that we are doing now, we are going for the opposite side, doing a bilateral stenting at the same time. And the third one, which we discussed, we'll be doing later today, and that would be again a possibility of bilateral stenting to be done at the same time.
Okay, Hinwa, thank you very much. So I congratulate you and your team. All the 3 cases done successfully, and this procedure has become simpler.
Thank you indeed. Thank you for being with us.
Ladies and gentlemen, that was the case from Ruby Hall Clinic, and the operator who is still on your screen is Dr. M.S. Hirimat, Director, Cath Lab. Thank you very much. We'd like to thank our members of the expert panel who have been part of the live case.